So the next speaker will be Dr. Stéphane Lehericy, who is a professor at the Department of Neuroradiology at Pitié-Salpêtrière Hospital in Paris, in France. He became the director of the Neuroimaging Center in 2007. Previously, he was a visiting assistant professor at the Center for Magnetic Resonance Research in Minneapolis in the States. His main research focuses on understanding the physiology of motor control and pathophysiology of movement disorders. So to achieve that, he is using various neuroimaging tools such as Neuromelanin-sensitive MRI and Quantitative MRI metrics.
Here we are. Here we are. Thank you very much for the nice introduction. Can you hear me well?
Yes.
I guess so. Thank you. That's the title of the talk. And the focus will be on both sequences because they are linked, and I will show that later. So the overview is substantia nigra imaging in Parkinson's disease with neuromelanin and iron imaging. Then how we can combine these to understand the progression of the changes in Parkinson's disease, the changes in prodromal Parkinson's disease, isolated REM sleep behavior disorder, and then some information on atypical Parkinsonism. First, the substantia nigra imaging. Dopamine, iron, and neuromelanin are linked into a neurometabolic pathway, the degradation of dopamine here, that will be transformed using oxidation and ferric iron into dopaquinone, and then be stored into neuromelanin granule and organelles here. So they are associated. But once the storage capacity of neuromelanin is overwhelmed, then this pathway can be derived to a neurodegenerative process with a toxic iron and increased oxidative stress with elevated iron levels and mitochondrial dysfunction, and this could result in a loss of dopaminergic neurons and neurodegeneration. So it's interesting to combine neuromelanin imaging and iron imaging. We can, of course, use neuromelanin imaging, where we can see neuromelanin here, or the iron imaging, either R2 star or quantitative susceptibility mapping. Using neuromelanin imaging, neuromelanized neurons are reduced, and we see a reduction in signal intensity, and iron is increased. The topography of the two is a bit different. If we look at the control values in this study here, published by a group in California, you have the neuromelanin content in controls, which is located mostly in the substantia nigra pars compacta in kind of purple here. And we have the iron imaging, which is here in red. And in Parkinson's disease, we have a reduction in the content of neuromelanin, and we have an increase in iron deposition. Mostly, the iron is visible in the reticulata, and that's also seen using histology sections, where iron here on histology is located mostly in the area of the reticulata, whereas neuromelanin is in the area of the compacta. Let's have a look at neuromelanin imaging. Dopaminergic neurons of the compacta contain a pigment which is neuromelanin. Neuromelanin is associated with dopamine metabolism, as we have seen, and this is the aspect of neuromelanin on an histological section of a dopaminergic neuron. The source of neuromelanin contrast can be probably due to the fact that neuromelanin bound to iron is paramagnetic, and we can see that on the T1 weighted image here, and perhaps also to magnetization transfer effect. In Parkinson's disease, there is a reduction of dopaminergic neurons, there is a reduction of signal intensity on the neuromelanin images, and also reduction in the volume. It can be used to categorize patients from controls with a high accuracy, just by visual examination of the images. It's a good longitudinal marker, so if you examine patients over time, and you have the control aspect, then early Parkinson's disease, 1.5 years, 2.5 years after, then advanced Parkinson's disease, about 10 years, and here 12 years. we clearly see a reduction in the volume of the substantia nigra with advancing stages of the disease. And here on the group map of controls, we see the location of neuromelanin in the substantia nigra with a reduction progressively in early phases of PD and in more advanced form of PD, starting from the posterior and lateral part of the substantia nigra and moving toward the anterior and medial, which is more respected at the beginning of the disease. So good longitudinal marker. Also, neuromelanin changes will correlate with striatal dopaminergic function, as seen in this study from this group here, where you have here the contrast of neuromelanin images, and here the labeling using PET of dopaminergic terminals in the striatum. That's the correlation. Or here using a voxel-based approach, that's a correlation between the signal intensity in the striatum for that and the neuromelanin signal intensity in the substantia nigra, and see a nice correlation as well. There's a correlation with motor and non-motor severity of the disease. And what is interesting here is the fact that if you look at the topography of the correlations, here for the motor changes, it's the posterior and lateral part of the substantia nigra, the one which is most affected in Parkinson's disease. It's a territory, the sensory motor territory of the nigra. When you have a cognitive scale, the Matisse dementia rating scale, it's more anterior and medial here. That's the associative territory of the nigra. And here, if you have a behavioral scale, for instance, here creativity or apathy, what you see is it is more medial here, very close to the ventral tegmental area. So that these are the territories where you have here the motor territory, the cognitive territory, and the behavioral territory on the axial view. That's for neuromelanin imaging. If we look at iron deposition, well, of course, you know we can study that using R2 star, and this group in Austria has shown that there is a good correlation between iron deposition and R2 star signal intensity here. And it's the same for quantitative susceptibility mapping, where you have here the susceptibility and the correlation with iron concentration in postmortem tissue. So these are good markers of iron deposition. Iron deposition is increased in the substantia nigra of Parkinson's disease. It is a diagnostic, reproducible, early and longitudinal marker. So it's diagnostic. If you compare patients and controls, you can see the difference. This is reproducible. Many studies have reported that. So it's apparently a good marker. It's observed early in the disease, where here you have the control values, R2 star value in the substantia nigra early in the disease, here in controls, and here early in the disease with de novo patients. It also increases with increasing disease severity, with probably a plateau after the first year of age. There's also a correlation with motor severity in some studies, but not all. Here, the motor severity of the disease, correlation with the R2 star for that study. And here another one, it's another study that has shown a correlation between body kinesia and rigidity scores with the here measurements in the substantia nigra. When studies compared QSM and R2 star, many of them have reported that the results are better. You can clearly distinguish better the PD patients here with increased susceptibility from the controls in the nigra and the pallidum, better than using R2 star. In this meta-analysis, the effect size for QSM was larger than for R2 star, but there was no differences in there were no differences in the QSM values between the different subdivisions of the nigra, lateral and medial, and the IPSI and contralateral side of the nigra. And also correlations with the motor score, UPDRS, were more frequently observed for QSM than R2 star. So it seems that R2 star is probably a little bit better to examine the changes due to iron in the substantia nigra. Also, iron deposition is greater in the compacta than the whole substantia nigra and substantia nigra reticulata. Here you have the contour of the substantia nigra using T2 weighted image in red, and here using a neuromelanin image in blue. It's the same as before, so more iron in the anterior substantia nigra reticulata than in the posterior compacta. But if you look at the increase in iron in Parkinson's disease, you have more increase in the compacta using neuromelanin image compared to control than in the reticulata using the T2 star contour here, where you don't see the clear difference. And here we have obtained very similar results comparing QSM and R2 star. That's the QSM region of interest. That's the neuromelanin region of interest. Changes are much greater using neuromelanin region of interest in the compacta than in the entire substantia nigra, both for QSM and R2 star. And this fits very well with the observation made in histological tissue, where you have here the control deposition of iron, more iron in the reticulata than in the compacta. And here, that's the values observed in Parkinson's disease, more iron in the compacta than the reticulata. So it seems that iron deposition is greater in the compacta than in the reticulata. Another sign which is also very interesting is called the dorsal nigral hyperintensity sign, or also the swallowtail sign, because it has the shape of a swallowtail. It's now very well known. That's a normal aspect at 3 Tesla, where you have iron deposition on the T2 star image that you can see here, and that's a susceptibility weighted image. You have a pocket of high signal intensity surrounded by 2 bands of low signal intensity, and this is called the dorsal nigral hyperintensity sign. Iron deposition occurs here, and you lose that sign in patients with Parkinson's disease, and it's even better seen at 7 Tesla, where you have here the dorsal nigral hyperintensity sign. It's very useful at the individual level for the studies that have compared controls and Parkinson's disease with a high accuracy to distinguish these two. Well, the question we can ask is whether this sign does correspond to nigrosome 1. So first, what is nigrosome 1? Nigrosome 1 is an area of the substantia nigra compacta here in the posterior and lateral part of the compacta, where you have the most changes in neuromelanin imaging. And it is seen using specific dyes in the substantia nigra. This is a calbinding staining. And you have pockets of low calbinding staining surrounded by the matrix, which is highly stained by the calbinding. And the largest pocket is called nigrosome 1 here. And this region degenerates very early and more severely than in the other one. So it's the one which is affected first in Parkinson's disease. And that study from the group in Leipzig has compared using histology and imaging at 7 Tesla, the subthalamic, the swallowtail sign here in blue, and the histological nigrosome 1 that you can see here in red. And what they have shown is that you have an overlap, of course, but nigrosome 1 does not fully correspond to the dorsal nigral hyperintensity sign. So the nigrosome 1 term should be reserved to histology, whereas the swallowtail sign is the one that we can observe using MRI. There is an overlap, but which is not complete between both. Now, if we try to better understand what is the correlation between what we observed in histology and what we have with MRI, you have some studies that are interesting doing histological correlations. This group in Leipzig, again, has compared the Pearl staining for iron staining in histological sections in a control subject, where you have here the nigrosome 1 area, and in a patient with Parkinson's disease, where you have an increase in iron deposition using that Pearl staining. And it's the same histological section using MRI at 7 Tesla, where you have here the R2 star image showing a very nice correspondence between R2 star and here the iron deposition using histology, and which is lost in Parkinson's disease. And that iron deposition can be quantified using QSM, and it's increased in early Parkinson's disease compared to controls here. So increased susceptibility due to increased iron compared to controls. This other study was also very interesting because, again, the same group in Leipzig in Germany, they have, again, used histological sections, and they have shown here that if you look at a very high resolution T2 star weighted image, you can see small granules that correspond to neuromelanin-rich domains of dopaminergic neurons. And if you extract iron from the tissue, you lose completely this contrast. So this is clearly related to iron. And this has exactly the same topography as R2 star map here. So that's nigrosome 1 in blue, and the same iron deposition here in the granules. Well, it's not related to R2, where you don't have that contrast here. And if you remove iron again, then the R2 star map becomes like the R2 map. So you clearly lose the contrast due to iron. And they have compared the R2 star, the one which is iron-induced in red, and the one which is without iron, with the R2 star. And what they have done is to make that subtraction, R2 star minus R2, R2 prime, and then you have the nigrosome 1, where you have increased contrast in this region, which compares very well in terms of topography with the neuromelanin deposition with optical density in the histological section. So in nigrosome 1, this contrast correlates very well with neuromelanin bound to iron. So the dominant contribution of R2 star in nigrosome 1 is iron accumulated in neuromelanin of dopaminergic neurons. And it's very similar in this study here that was published before by a group in South Korea, where you have the T2 map corresponding very well to ferric iron, and the T2 star over T2 map, which correspond very well to neuromelanin bound to iron. So it's apparently possible to distinguish the different forms of iron, the one linked to neuromelanin and the one which is not. Let's have a look now at the imaging-based model of neuromelanin and iron. If we look at all the patients in that study, from early patients to advanced PD patients, and we make that curve of decline of the volume of the substantia nigra using neuromelanin imaging, then we have about 5.3 years from the normal values of the controls. So it seems that the decrease in neuromelanin volume starts about 5.3 years before we can detect Parkinson's disease with motor signs. And this has been reproduced more recently by this group in Nottingham, where they have observed the same finding with a disease duration of about 5 years before between the beginning of neuromelanin changes and the beginning of the motor signs. And now, if we do the same type of analysis for DAT, so these are the dopaminergic terminals in the striatum. In the sensory motor compartment, the most affected, more red, then the associative compartment, which is less red, and then the limbic compartment, which is least affected. The changes will start about 10 to 20 years before for the sensory motor territory, about 10 years for the associative territory, and a few years before the onset of the disease for the limbic territory. And for neuromelanin deposition, it's very similar. The one which is most affected here is the sensory motor territory, this one, the posterior and lateral part, about 10 to 5 years before disease duration. And that's for QSM, for iron deposition. And for neuromelanin changes, it's about 5 to 0 years. So here we have the changes in this order. First, changes in the dopaminergic terminals, so striatal dopaminergic dysfunction, then iron deposition, minus 10 to minus 5, and then neuromelanin changes, minus 5 to 0. Let's have a look now at REM sleep behavior disorder, because this is a prodromal form of Parkinson's disease. It's a parasomnia in which patients will move during REM sleep, so they act their dreams. This person here is recorded during a night's sleep, is in REM sleep, is dreaming, and is moving the dream. Well, of course, when you dream, you don't move. This is absolutely abnormal, and it's due to the fact that the motor system, which is controlling movements during REM sleep, is affected by Parkinson's disease. And it's mostly in the area of the locus coeruleus subcoeruleus. If we detect that in patients without Parkinson's disease and we wait for a long time, then most of them, if not all of them, will develop at some point a synucleinopathy. Parkinson's disease, multiple system atrophy, or dementia with Lewy body. That's a term, the kind of Kaplan-Meier plot that you can observe in these patients. So after 10 to 15 years, almost all of them will develop some kinds of synucleinopathy. And they have also, if you examine neuromelanin imaging in the substantia nigra, a reduction of the volume and the signal intensity in the area of the substantia nigra compacta. Less than in PD compared to controls, but still we have some degree of degeneration there. Apparently non-significant increase in iron deposition. At least with the study that we have done here, where the isolated RBD are here, it's an increase that we can detect in the neuromelanin region, but not in the entire substantia nigra with QSM. So again, like previously in Parkinson's disease, but it did not reach significance. So still, it's a double the value for susceptibility, but it was not significant. And the last sign is the fact that in isolated RBD patients, you lose again the dorsal nigral hyperintensity sign, which clearly shows that you have iron deposition in the area of nigroso 1. This sign is lost in about 2/3 of isolated REM sleep behavior disorders. Isolated REM sleep behavior disorder means that they have a REM sleep behavior disorder, but not yet Parkinson's disease. It's just isolated RBD. And also, this study is interesting. It was obtained by this group in PISA in nigrosome 1 because they have shown that the susceptibility increase in iron deposition correlates with disease duration here in isolated RBD patients, but no more in patients with Parkinson's disease, as if the changes were occurring before the onset of the disease, as we have shown in that previous study, simulating the onset of the disease. Here. And after that, then we reach a plateau and the iron deposition stays stable. And a few words to finish with PSP and MSA. Well, PSP is a tauopathy, and it affects mostly the midbrain, which is clearly atrophic here, whereas multiple system atrophy forms are synucleinopathies with a Parkinsonian form, an atrophy of the putamen with iron deposition, and a cerebellar form with an atrophy of the pons, here the cerebellum, and iron deposition in the dentate nucleus. So we'll focus on this form, the Parkinsonian one. First, all these forms will show reduction in neuromelanin imaging in the substantia nigra, PD, PSP, MSA. See reduction in the volume and signal intensity. But tauopathy here, PSP, is mostly affected in the limbic and associative area, whereas PD and MSA is mostly the sensorimotor territory. So the territory apparently is different. And for the dorsal nigral hyperintensity sign, that's the same. Iron deposition, you lose that in PD, in MSA, in PSP as well. So it does not distinguish the different forms of neurodegenerative Parkinsonism, but it's normal in vascular and drug-induced Parkinsonism and in essential tremor as well. And if we look at iron concentration changes in PSP, then we have a lot more iron deposition in many more regions. That study of that group in Sweden, Karolinska, has shown iron deposition in PSP in the globus pallidus compared to controls and PD, in the putamen, the substantia nigra, perhaps more than in PD, the red nucleus, and the dentate nucleus. And the one that was best to distinguish the two groups, PSP from the others, was the red nucleus. So the red nucleus is specifically affected in PSP. Whereas in multiple system atrophy, the Parkinsonian form, here, it's the putamen. You have here controls, PD, MSA, PSP, and that's clearly in MSA that you have more iron deposition, either with R2 star or here with QSM, compared to here PSP. So more R2 star, less. More QSM, deposition, and less. So in summary, substantia nigra MRI in Parkinson's disease shows reduced signal intensity and volume for neuromelanin imaging, changes that predominate in the compacta and in the area of the nigrosome 1. Neuromelanin-sensitive MRI detects the paramagnetic neuromelanin iron complex. And in nigrosome 1, the dominant contribution to R2 star is iron accumulated in neuromelanin of dopaminergic neurons. In isolated RBD, a prodromal form of Parkinsonism, we have reduced neuromelanin signal and increased iron deposition in the nigra. And in atypical Parkinsonism, we have also, as for Parkinson's disease, reduced neuromelanin signal and increased iron deposition in the nigra. And the iron deposition, which is observed in many different regions in PSP, particularly in the red nucleus, whereas it's mostly observed in the putamen for the Parkinsonian form of MSA. And I'd like to thank all my colleagues in Salpêtrière Hospital and ICM, and also you for your attention, and I'm open for any questions.
Thank you so much for this great talk, and it's great to see so many applications of what we've seen before. So Olivier, do we have any questions on the chat?
No, there's no questions in the chat yet. Okay,
so I will have one actually. So you were saying that based on different results, you were expecting certain biomarkers to start 5 years or 10 years before the onset of the symptoms. And I was wondering if you actually tried to look at autosomal dominant population to see if indeed it was the case. I don't know if it's available for Parkinson's disease.
These are rare cases. It's of course very interesting. Probably we'll have the same results. What we have done is a study in patients with LRRK2, and in these patients we have seen that increased iron deposition is observed in genetic carriers, unaffected genetic carriers of the mutation. So this is a mutation at risk of Parkinson's disease. They are not affected, they are just carriers of the genes, and they have increased iron deposition. Some other studies have shown also a reduction in the binding of dopaminergic tracers in the striatum. For neuromelanin, we are also working on that, but I don't have firm results yet.
Thank you.
Thank you. Still no questions in the chat, but I will have one question. So when you say iron deposition, is it mostly extracellular iron deposition, and what biologically would cause that? I'm curious.
For iron deposition? Well, iron is observed in many different compartments. You have iron bound to ferritin, you have iron bound to neuromelanin, and you have also free iron. And I'm not sure that we can distinguish actually those with the techniques that we have used so far, R2 star and QSM. Well, it's possible when you use the very high field imaging and the different types of contrast. But using just QSM at the moment, I don't think we can clearly separate that. So for the clinical studies, this has to be done. For the post-mortem studies, I think it's encouraging, and it says that we can do that. But then if we want to use these type of sequences in living patients, they are a bit long, and it's also difficult to scan these patients with long sequence.
And thank you so much. Do you have a question, Olivier? Or?
Maybe one question, yeah, from Soyeon Ji. And so are these results of increased volume of iron deposited areas in PD, and also are there lateralities of images related to the laterality of the disease symptoms?
For neuromelanin imaging, yes, it's mostly affected on the side which is contralateral to the most affected clinical sign. For susceptibility and mapping and quantitative susceptibility mapping and iron deposition, it's not so obvious. It's many studies did not find a clear difference between the two sides. So yes, for neuromelanin, and probably less yes, even no for QSM.
Okay, thank you so much again. And so we are going to move from the program.